Hello, good afternoon, and welcome to this session. Actually, last year I presented our 2 years data of the primary PCIs, and this year I'm going to present this pharmacokinetic therapy. For STMI patient, you know the immediate reperfusion is very much needed, and options are primary PCI, that's we are doing in our hospital, fibrinolysis, and PCI. That include rescue PCI, immediate or facilitated PCI that is no longer recommended, pharmaco-invasive PCI within 3 to 24 hours, and deferred PCI. And this is the recommendation guideline from the European Society of Cardiology. Primary PCI is the best option and is the preferred option. But scenario in Bangladesh is different, already mentioned our previous speaker. Primary PCI capable centers are very limited. Cost is also very high, particularly out of hours from 5 to next day morning. It is very expensive. Lack of awareness among patients and the doctors, traffic delay. These are then trained manpower. These are the time limit of different source of here. All you know. And why lysis is an option with PCI, before PCI. Reopening of the infiltrated artery, early reperfusion, PCI easier if you do the lysis, and definitely less thrombus burden. And the bad side is the bleeding and prothrombotic state, also cost increase. So indication of thrombolytis, all we know. And these are the available thrombolytic, streptokinase, altiplase, second generation, third generation, tenecteplase. This is a very old trial, and this is the trial that came to head to comparison with the primary PCI, the pharmaco-invasive therapy. 212 patients included. Those received tenecteplase with primary PCI one group, and they evaluated the 6 weeks report of the LV functions, myocardial reperfusions, bleeding, and secondary outcome was death, reinfection, stroke. And this trial shows it is almost equivalent with the primary PCI. No difference in composite ischemic endpoint or LV function despite the error delay in pharmaco-invasive therapy. Subsequently, the STEM trial, if you do the PCI after thrombolytis, this TIMI flow is tremendously, it's more than 95%. And the transfer AMI trial also showing the same here, death, non-fatal reinfection, recurrent ischemia, new or worsening heart failures in 30 days. It is also showing the pharmaco-invasive therapy is far better than the standard therapy. So what is our experience? Actually, we do all primary PCI, but during the COVID period, our primary PCI was full. So all the data in the 2020 and 2021, 79 patients included, all are RT-PCR negative. And 88% patients are male, only 11% are female. This is the age distribution. Majority all have the some sort of risk factor, 40% hypertensive, 38% diabetic, 33% smoker. And these are the baseline. Average duration of the chest pain, 3 hours from the chest pain to the contact. And then again, more than 3 hours to come our hospital. But once reached in the hospital, majority of the cases, thrombolysis done within 1 hour, within 50 minutes. And CAG average duration 28 hours. It was not 24 because the COVID period, all patients depend on the RT-PCR report. It was delayed at that time. So types of MI, around 52% are inferior MI and 48% are anterior MI. And the types of thrombolytic we use, 58 patients receive tenecteplase, 21% receive streptokinase. This is different from the rest of the country because we are using mainly the tenecteplase, third generation thrombolytics. And the CAG findings are 46% LED lesion, 41% RCA lesion, and the 13% LCX lesion. Out of the 79, 17 patients have a zero TIMI flow, 100% occluded in the angiogram. And majority of the patient after thrombolytis, TIMI 1 to 2, only 6% patient have the TIMI 3 flow. And the types of intervention, Out of 79, 67% receive PCI with stent, 6.4% patient goes for CABG, 5% patient for the medical management. This is the average size of the stent use in patients. And the complication in hospital, 79% doesn't have any complication, failure around 9%, cardiogenic shock 6%, arrhythmia around 7%. In hospital, mortality was almost 4%, but majority, 96%, discharged to home. So primary PCI is the best option, no doubt. In our hospital also, it is best option. And we are doing only the primary PCI. Results of pharmaco-invasive therapy, we started during the COVID period, but incidentally, we found it is comparable to primary PCI result in our hospital. It is not inferior, though we are doing almost 100% primary PCI. So pharmaco-invasive study is a good option for our patient where resources are very limited and facilities are also limited. Thank you all for patience hearing.
Thank you, sir.